our piezo tome. And let me come over here, show you the handpiece here. So what we've got here is a piezo with a peritome on here. So this will vibrate and this will help separate the periodontal ligaments. And I'll show you how we use that. We like to use it around the distal, the mesial, and the palatal, but very infrequently would we actually use it on the facial of the extraction site, because the bone there is typically way too thin. So we'll set that aside for just a minute and we'll show you how that works in just a second. So the first thing I'm going to do on the table here is I'm going to pick up my Molt 9 and my Minnesota. We're going to come to the mouth. I'm just going to slightly elevate the papilla with a little twisting action. And then we're elevating off. We don't have to do a big elevation. I just want to be able to see the neck of the tooth. And then I'm going to come to the lingual side and do the same on the lingual side. So that's it right there. Just very quick. Want to be able to get down on that. And then let me show you how this piezo works. So the piezo has a piezo tome on it. This one looks like a samurai sword. And what we want to do is we want to go right down to the periodontal ligament, so I'm in the mesial here. And we're going to do a rocking action just like this. So as we energize, we do a rocking action, and we give it just a little bit of apical pressure, and it slips right down. Now I'm going to go to the distal side here. And it just slips right down. So this Acteon product is new to me. It just came last week. I've been using piezos for a long time. But the Acteon people told me that their product is substantially faster than historic piezos. And if you know anything about piezos, you know that they're historically they're a little slow, but this thing is cutting like a laser through butter. I am very impressed so far. Yeah, that's really sliding in there quite nicely. So I'm on the palate. I'm probably blocking your view right now. Okay. Can I get the spoon? There's a little piece of soft tissue here that's in the way. We're just going to get that out of the way real quick. A little granulation tissue there. Okay. So my favorite instrument for taking out premolars is an ash forceps, and there's a mechanical advantage that's provided by it, by the way that the pivot axis is different than the handle axis. And for this particular tooth, I'm just going to try to hold on to what's remaining of that tooth number 5, and just kind of give it a little twisting action. Now, on the cone beam CT scan that we have for this tooth, we noted before we started that it has a very distinct buccal and palatal root, so we want to be kind of careful. We don't want to slow down our process by separating that, but a little bit of a action to the buccal and to the lingual go ahead and facilitates the removal of the tooth. So the tooth is out now. Now note, this tooth is oval in shape, and what we're getting ready to put in here is a dental implant, which is circular in shape, which means that there's a gap. So at the end of the procedure, what we're going to do is we're going to graft the gap. We're going to graft the gap between the circle that's on the implant and the oval that is the extraction site. So the first thing we're going to do is come in here, and let me see if I can get a mirror in here. So let me see if I can get this giant mirror in here so you guys can see a little better. How's my view there? Better? Okay. All right, so all of the radicular bone is still intact, and that's great, and we don't feel any soft bone here. I'm also engaging the buccal plate to ensure that I have buccal bone there. If I didn't have buccal bone there, then I would use a collagen barrier membrane, slip down into this little flap that we've created, but since the bone is in the ideal location, we're not going to put any collagen on the facial. Okay, so that's it. It's nice and clean. I don't see any infection in there at all. So we're going to go to the next step, which is guided surgery. Now let me show you this guide real quick here, up close. Margaret, if you can just tell me when you're good.
Bring your hands up 1 inch towards the surgery kit.
This way?
Towards the surgery kit, other direction.
Towards my husband's kit.
That's good.
Okay, right there?
Mm-hmm.
So this is our surgical guide. This was fabricated by Vulcan Dental, and we did our digital planning on our Trios scanner and then our iCat 3D, and merged together in some planning software. And in the planning software, we planned the placement of the implant, and then we also planned the actual surgical guide. Then we sent this as a file off to Vulcan, and they simply printed it. And it comes back. It's color-coded, so note that the sleeve here is gold, and you'll note here that my inserts here are gold. They're designed to match. And what we're going to do is we're going to step through a series of sleeves here. These sleeves change in the inner diameter, but not the outer diameter. The outer diameter always stays the same so that it registers with the master cylinder inside the guide. These little cutouts right here are for us to visualize right here and here. These are for us to visualize that the guide is actually seated firmly on the remaining dentition so that we get our depth right, because not only does this account for position, but it also accounts for depth, and we'll show you how that works in just a second. So at this point, what I'm going to do is I'm going to go to the mouth with the guide, and we're going to try it in. And so that's in the way. So we have a mouth prop on the other side that's bumping up against it, so we need to make sure that's out of the way. Now that's down nicely, and let's make sure in our little viewing windows that we like the position looks good there. And it's up a little bit on this side. So Sarah, if we can get a smaller bite block, we can put that in the back here. So I'm going to take this out for a second. We're just going to go with a smaller bite block. So I'm not going to give up the airway until Sarah's ready. Okay. You have a string on that? Good. Okay. So now that should be out of our way as we go back, and the guide sits down quite nicely now. And we're going to verify one last time, because we're going to measure twice and cut once. I want to make sure that that guide is seated. Now it's going to be difficult for you to see this on the camera, but through this little viewing window here, let me see if I can get one in here, you can see the tooth right there, right towards the distal aspect there. You see the tooth is intimately adapted to the guide. So we're going to check, there's the mesial side of it. Let me see if I can get a better view. Let me use the bigger mirror. Let's see if we can get that view for you. There we go. So you see where that little bit of hemorrhaging is? Right on the, get a pointer here. I'll point this out to you. So we're going to check right there to make sure that that tooth is adapted to the plastic, and it is quite nicely right there. And then we're going to check the front. So if I angle this for you, we're going to check the front as well. So we're going to go up in here and make sure that this side's touching. So they're touching on the mesial and distal of that tooth on the guide, and the same thing goes for this one over here. So back here, it's touching firmly. If it's not, you just make sure it's seated. Okay? So we're happy with the vertical dimension. It's seated quite nicely. At this point, we're going to step through our protocol. On the, Margaret, if you'll go to cam 2 for a second.
Sure. You had a question. Somebody asked if you prefer guided surgery for full arch cases.
I absolutely love the guided surgery for full arch, and I hope to, in the very near future, actually put one of our full arch courses on this Implant Compare and show you how we do it. The entire process for a full arch, say we're going to place 6 implants, take out all the remaining dentition, place 6 implants, and restore them with a long-term provisional, which would be a metal framework with a PMMA overlay. Typically takes about 2.5 hours, and that's from gloves on to gloves off, which is substantially faster than most denture conversion cases that you try. And the accuracy that the guide provides really drives that case. Takes all the guesswork out of it. What I want to show you here is on the back wall here, what we've done here on the back wall is we've taped up the surgical report. So the surgical report has some key information. In the surgical guide, it will have a drill length and it will have a drill stop position for us. So in this particular case, if I come back to my overhead camera here, Margaret, can you see the surgical guide here, the surgical kit?
Yes, turn the light up.
Okay. So in the surgical kit, there is, starting from the left column here, working your way to the right, what happens is that the drills just get bigger in diameter. So they just get fatter as you go this way. That's all you have to remember there. From the top left corner going down, what you'll notice, there's a number here, 17. That's a 17 millimeter drill. The next one's 21, 24, and 28. Now, on the back wall, the script will tell me which drill I need to use for the case. In today's case, we're using a 24 millimeter drill. And I told you earlier that the guide has a yellow color to it. So we're doing yellow, and yellow is indicated in 24. It stops right here. So we're only going to drill straight across till we get to this color-coded yellow. Once we get to this yellow, we know we're done. That's it. If we were placing a bigger implant, it might be a green implant, we'd go to here. If we were placing a bigger implant, we'd place the blue, we'd go to here. So today, just a yellow, so just 4 drills. Here's a little tip. These is my, am I in the camera there, Margaret?
Come down just a little bit.
Down?
I think it's down.
Pardon?
I think it's down.
Can you see this?
No.
What do I? Up?
The other direction.
Okay.
That one.
Okay, great. So let me just turn on the light for a second. Okay, and we'll turn the light off. Okay, so these numbers are hard to see here, and the inner diameter is only changing by a few tenths of a millimeter. So if I go from a 2.8 on this end, and I show you on this end, this is a 3.2, it's only 4/10 of a millimeter. It's hard for a doctor to visualize which end is the small one. And this little carrier is neat because you can just turn it around. It facilitates a quicker surgery. So in order to determine which one's the small one, what Sarah does, my surgical assistant, what she does is she puts a little yellow, what are these called? These are the bands you put on your instruments for so you can run through sterilization and put the kits back together. So we just put a little yellow band on one end. And that is always going to indicate the smaller dimension. It's always going to indicate the smaller dimension. That way I don't have to worry about which end's the small end. I just pick up the yellow end. I know that's the starting end. So what we're going to do is we're going to start off with the 2.0 drill with a 24 length. The drill has a stop on it, so I don't need to worry about depth, because once this goes down, it goes all the way down until it bottoms out on the collar, and I'm done. So I just take this all the way straight to depth and come back out. Let's show you how that works. Okay, so the 2.0 sleeve, now this is a little trick. Sometimes people will ask, hey, how do you deal with cases where you can't get in? Well, this is how you deal with cases that you can't get in. If you put the sleeve in first, and then you try to put the drill in, the drill has to be perfectly aligned in order to go in. If I put the sleeve over the drill, like this, I can put the tip in at an angle, then I can straighten and I can drop back in. Now notice that the interproximal distance here, the inner arch distance here is much smaller because I'm dropping into the hole. So this is how I do it probably 90% of the time. I put the sleeve on the drill tip goes into the hole, which allows it to seat. Then we just wiggle the guide sleeve until it's seated, and then we're ready to go. So I'm pushing on the apices of the hole, and you can see here clearly that even though we've just taken the tooth out, we're touching bone from here to here. So we've got a good 10 millimeters of bone that we're engaging in the radicular bone space. All right, so lots of water, and we're done. One of the things that's most important when you're doing guided is don't waste time drilling in the bone where you don't need to be. So what I've done now is I've switched the drill to a 2.5 drill. I've turned it from this end over to this end, and now we're ready to go on this end. So I'm going to do the same thing. I'm going to come in with a tip. I'm going to wiggle my guide sleeve until it marries up nicely with the master cylinder, and then we're going to drill, and we're done. So there's a lot of folks that will say, Doc, are you worried about heating up the bone because the water can't get down in the hole? And I say, watch me do this case right here. Okay. Now, I want you to rub your hands, if you're watching on the internet, rub your hands together as long as the water's running, okay? Okay, did your hands get hot? And the answer is no, because I'm not in there. Now, if you were to go down into the bottom of the hole, into the bottom of the extraction site, and wait and leave your instrumentation in there, then of course you could potentially heat that up. So once you get to the bottom, once you get this collar is all the way down, you come right back out. You don't mess around. So watch again. This is the last one now. This is the fourth drill. We're done. Now note here, on the flute here, we're picking up red bone. Okay, red bone is what you want to see. Why? Because that means we're in trabecular bone, which means it has a very good bone supply, blood supply to the site, which is what we want. We're not engaging it on the tall flutes up here because we're going into an extraction site and there's no engagement there. So the rule of thumb that we use, that we teach, is that if you have 5 threads engaging apical bone, you're probably going to get good primary stability. So when we did our digital workup today, we wanted to make sure that from the bottom to somewhere in this region, we had about 5 millimeters of bone, or that correlates to about 5 threads. So we call it the 5-thread rule. If you have about 5 threads engaging the bone, then you're likely going to get a decent primary stability. And it's a guideline. So if you're going into softer bone, you're going to want to maybe 6 threads. If you're going into really dense bone, you might be able to get away with a little less. So what we're going to do now is, I'm going to turn on the overhead. All right, Margaret, can you see this clearly?
Go ahead.
Okay. Can you see this clearly?
Yes.
Okay. Can I get my, there we go. So this is our driver. So on the top of the driver, we just have an iso latch.
Bring your hands up 2 inches.
When you say up, you mean towards the window?
I do.
Okay. There?
Yes.
Okay. So what we have here is an iso latch, and then we have a driver. This is going to engage the implant here. These little dots are what we use when we're doing full arch cases that we need timing, or when we're doing anterior cases where we're doing a timing. Timing is a setup where that dot lines up with the flat on the inside of the hex of the implant, and that's important for angled multi-unit abutments for full arch cases for sure. There are 4 grooves in this driver. There's 1, 2, 3, and 4. These grooves are the stop positions. Recall earlier I told you that we had only 4 lengths to our drills. Well, we have 4 lengths to the drill, but we make up those differences with this driver adjustability. This is a little snap link that's adjustable. You can pull it out and reset it. For our case today, we're setting our depth position to an SP3 position, okay? So it's 1, 2, 3. It's in the 3rd position. So when I drive the implant, I'm going to drive the implant until this plastic snap link touches the top of the guide, and we are done. So let's go ahead and pick up the implant. Margaret, your overhead cam 3, does it pick up the front of the BNR? Okay. Will this do a decent job?
Yes.
Okay. So if I put that like that, can you see most of that? Pardon? I want the Foodident to show the front of the BNR unit.
Yes, that's pretty good.
Okay, so in general, I want to show you this BNR unit. Now, we just got this a couple years ago, and we're really keen on it, and here's why. When I switch from 1 to 4, and I do that by stepping on a button on the rheostat on the floor. When I go to 4, it goes to implant mode. So it sets the RPMs to 20, and it's going to measure my real-time torque insertion. So as I engage bone, this little green arrow on the bottom will start to slide up. If we max out, it will max out at 70. I don't suspect that it's going to max out since we're going into an extraction site, but if we were going into a healed site, quite readily, we max out at 70 Newton centimeters. Oh, that looks great. Thank you, Doc. Okay, so what I'm going to do now is I'm going to change the position here.
Yep, that looks great.
Okay, so what I want to do now is show you that the implant comes in a sterile container, so I don't want to touch the implant. Here's my driver, so I'm going to come in and I'm just going to engage it from an angle and then wiggle it until I insert. That little hex has to go into the inside of the implant. So once we get it kind of engaged, and it takes a little bit of wiggling to get it to engage, then we'll be ready to take it to the mouth. And it normally doesn't take this much effort to get it to engage.
Only because we're filming. Is that the right driver? It looked like there was a groove on it to me, is there not?
Yeah, this is the wrong driver. So this is a yellow to gray. So we need another driver. So the drivers are color coded. So let me show you.
Is it something completely different?
No, that's just a yellow driver. So I
It's
need.
not yellow to gray?
Yeah, but it's the wrong way. So give us a second to grab the right driver. So
Dr. Rob, while you're waiting on that, we have a question. Dr. Terry asked if you've ever used VersaBurs with guided surgery.
So the question is have we ever used VersaBurs with guided surgery? And the answer is no, we haven't used VersaBurs with guided surgery. However, I have been known to use my drills on an off-label use. If I'm doing an implant in the upper posterior where the bone is really, really soft, then I've been known to stop short of the osteotomy's final diameter and also potentially use the second to last drill and run that in reverse at a very, very slow speed to attempt to condense the bone in that region. And I've had good success with that. Okay. Where's the driver? Here? Yeah, that's it. That's it. Okay, so then let's go back to this overhead camera here real quick. Am I in a good view there?
Yes.
Okay. And do I have my pointer? Here it is. So let me show you what's going on here. We are placing a yellow implant, but there's a little silver groove above here, and this silver groove tells me that this is platform switched. So I like platform switched. It's pretty much been proven throughout the industry that if you use the platform switched implant, you're going to maintain more crustal bone. So I always like to use an implant that gives me more crustal bone. So this is color coded. Yellow is remember the yellow was the color on the sleeve here. So on this sleeve right here, we were using yellow. This is a yellow implant, but the top is a little smaller. The top is one stop down from yellow, and when you come from yellow, you go down when you go to gray. So they didn't actually paint this gray to save some money, which makes sense because the metal is kind of gray. But that's the right driver now. So we've put our snap link back in at the SP3 position, and now we're ready to try to pick up that implant and see if it goes properly this time. Okay, so am I in? Okay. So now we're going to come in with the implant driver and we're going to wiggle it and just kind of do it. And now it goes in. That's the way it normally does. It normally goes in quite readily, quite fast like that. Okay. So what we're going to do is carry it to the mouth. And when I carry it to the mouth, I'm always going to carry it this way. So I want gravity working for me because I don't want that to fall off. And when I go to the mouth, I'll show you when we get to the mouth, I'm going to come at it from a back to front perspective. And let's show you how that works. Okay. Are you on the overhead now, Margaret?
Uh-huh.
Okay, so we're going to come into the mouth with the back of the driver, with the back of the drill, because we're going to come forward like this and then place it. The other way it would be to turn this upside down and try to go in this way. And if I tilt this any further down, it's going to have gravity working against me. So I want gravity working with me the whole time, so I'm going to come down to the back, come past, and then come forward. So there's little chance that the implant might inadvertently fall off while I'm placing it. Now I've got it in position. I'm going to check my drill settings and make sure that I'm set to the implant placement mode, and I am. So now I'm going to lightly step on the rheostat and then just let it turn. Now, when you're doing guided surgery, you don't want to apply a whole lot of apical pressure. You want the threads to engage, and you want the threads to drive the implant down and pull it into the hole. So we're using a BioHorizons implant today. BioHorizons has about 1 thread per millimeter. And that means that every time you do one full 360-degree turn, it's going to engage, it's going to move apically 1 more millimeter. Now that little snap link, sometimes it will catch on the part of the guide, and that's not a problem because I'm waiting for it to get all the way down there. All right, so I'm fully down. Let me see if I can give, before I take this out, you a very good view here from the side. Let's see here, a little bit of air. Can they see from the side view there? There. So look in the mirror and notice that the snap link is flush with the top of the guide. That means we're at the proper depth. So implants placed, that whole implant placement process took about 17 seconds. Now if I come back to I'm going to take this out and I'll show you what our torque readings were. So sometimes this gets stuck, but today it didn't. So it came out just fine. And we can take the guide out. We don't need the guide anymore. So the guide's out. And in just a second, I'll show you what we're going to do. But let me come back to this right here.
Come down just a little bit towards the table.
Towards what?
Towards the table. Right there.
Okay. So here's the take-home point. Right now, we have 17.6 Newton centimeters of torque on the implant. And I'm sure someone's wondering, well, how low would you go? Well, I've gone as low as 10 Newton centimeters on an implant and had it work. It's not something I would recommend. It's not something that you want. You want to have more initial stability on your implant than less. But in an extraction spot like this, if I can get close to 20 and then graft around it and then put a healing abutment on that's right at the level of the tissue, we've found that we've had good luck. So I like this. When we're done with this, Sarah takes all of this data and exports it as a PDF. It goes right into the patient's chart. And so you have a very, very good record of what was placed. It records, it actually scans in the implant by the barcode, puts all the data in here, and then includes the actual surgical output, which was how you actually placed the implant. It was really, really handy. All right, so we're going to come back to the mouth. At this point, what we're going to do is we're going to put a healing abutment on. Now, we've designed this digitally, so we know that we wanted the implant to be 3 millimeters below the desired free gingival margin from the 3A 2B roll that falls out of Lyndon Cooper's work at the University of North Carolina, Chapel Hill. And so what I've selected here is a 3 millimeter healing abutment. Okay, so throat screen's in place. Always want to have a throat screen in place. And I'm going to come in here and I'm just going to lightly engage the implant. At this point, it's very important to have delicate fingers because any off-axis rotation at this point could dislodge your implant from the precarious position that it's in. So notice that I'm applying just apical force very lightly with this finger, very, very lightly, and then allowing the threads to do their job until it's snug. And I'm going to give it just a little twist, not a big one, but I want to make sure it's just a rotational force, not an off-axis load. Now I'm pulling it out. The driver comes out of position and the implant's down, the healing abutment's down. So at this point, what we want to do is take a quick radiograph to verify that our position's right. So we'll do that. We like the Nomad for implant placement because it's very quick, allows us to get into tight spots quickly.
This is the wrong holder, I'm sorry. You want this one? Or you want the green one?
Green one. So we grab the left hand sensor holder. We got to grab the right-handed one. Now I like to take the radiograph prior to placing the bone graft. And the reason I like to do that is because for whatever reason, if there was ever a reason that the implant wasn't in the right position, I wouldn't want to go through the process of adding a graft on top of that and then having to pull both of those out. So what we're going to do now is we've got this nice little handy plastic holder, and we're going to use the Nomad to get this radiograph.
Dr. Runt, while you're taking that radiograph, if you have a question
Okay, so let me answer that in just a second because I can't chew gum and walk at the same time. Sarah, can you step out of the way of the beam? Thank you. Okay. All right, so how can we best show the radiograph, Margaret?
Pretty good. You can see it.
Oh, can you see it on the? Okay, great. Can you make it any bigger? There we go. So we're going to the full-size camera. Let me move this out of the way so you guys can see this a little better. So if you want, what we'll do is we'll post this to Implant Compare later so you guys can see the radiograph. But the really neat thing about it is that you can see the lamina dura around the crustal, around the top, right up in here. You can see the lamina dura on both sides of the extraction site. And you can see that we've actually engaged the bone in the last 5 threads. So these apical 5 threads are the ones that are actually giving us the 19 Newton centimeters, 17.6 Newton centimeters of primary stability are coming from this portion. This portion right here, we want to graft. So that's what we're going to do right now. So the question about the piezos, that was my first time using that, and the salesman told me at Chicago Midwinter that the Acteon product was substantially faster than anything that had been on the market previously, and I will have to substantiate that claim based on one procedure now. I can give you much better feedback after I use it a couple times, but I've been using piezo for a number of years. I use it predominantly for atraumatic extractions and for sinus grafts. And this product was substantially faster today. I'm very excited about it, and I can't wait to use it some more. Okay, so we're ready to do our graft. So what we need to do is we need to hydrate. Let me get this into position here. Okay, can you see that, Margaret?
Yes.
Okay, so this is our bone graft. This is our bone graft material. It comes from BioHorizons. It's called Minerals. It's mineralized cortical cancellous chips. So it's dehydrated, so we have to hydrate it. They've just changed to this neat little package which has a smooth round bottom, which is very, very convenient for scooping out the bone. If you're going to mix this in a dish, which we did for years on our own, you don't want a dish with sharp corners because you'll lose a lot of your bone particles in the corners. None of your instruments will get in there easily, and it'll slow you down. So what we're going to do is we're going to change the speed on the drill back to the original drill mode. And then I'm going to bring the handpiece into position. I'm just going to step on it lightly, and what we're going to do is hydrate our bone graft with normal saline. And that's it. Now that's a little more than we need, and you saw that I was only on the rheostat for just a second. So what we're going to do now is we're going to mix it first. Yeah. Well, I'll show you a little trick. We'll show you the little trick first, and then we'll mix it. So a little trick is just to take a little 2x and touch it right on the water, and it just wicks up all the excess. So you don't want to wick up too much. You want to make sure that you have enough in there. And that's pretty good right there. Good. So you just want it wet, and that's going to be fine. There's probably somebody who's wondering, are we going to add any antibiotics to this? We are not going to add any antibiotics to this. I typically don't add antibiotics to a single root bone graft on an immediate extraction. However, we do have the patient, I'm going to hand this back to Sarah now. We do have the patient start with a prophylaxis of antibiotics prior to the surgery so that he has circulating antibiotics in his bloodstream. Because remember, once we form the clot is dead. There's no blood supply to the clot, and therefore if we don't have antibiotics in the clot prior to forming it, it's not going to do us all that much good later on. So we have them take that 1 hour prior to the procedure, and we use amoxicillin for most people. That's 1,000 milligrams 1 hour prior to the procedure. Okay, so what we're going to do is we're going to use some very neat instruments. Am I in your view here?
Come down a little bit.
Okay.
Towards you. Right there.
Okay, so this is a product called a pocket packer, and it's curved. It's like a condenser. Think of like just a regular condenser you'd use for any restoration you're using. But at the tip here, I don't know if you can see that quite readily, there's a curve to it. And what this does is it allows the concave side over here to fit up against the implant, and the convex side on the outside here to slide between the bone and the implant. And this facilitates a very nice packing, and the other side is the same but just reversed in direction so you can get into tight spots. So let's, yep. It's made, this particular product was made by Hugh Freedy, which we like their products because they're made in Chicago. Okay, so what Sarah's going to do is she's going to bring the bone graft to the lingual side. We're going to do this four-handed trick. She brings it to the lingual, and all I do is just scrape right off the top like this into the hole. Okay? And then I say, okay, I need another one. And I'll say, come a little bit more facial this time. It'll be right over the implant. Now she's coming over the implant. I kind of sweep right off the top into the facial. And then when she feels like that she can't see, that means I can't see. And what she does is she does that little wicking trick. So once again, look how clean that bone graft looks right there, if you can see that readily, when we blot it with the gauze. So as you're working, as the heme rolls up into the socket, it's difficult to see what you're doing. So every once in a while, you need to blot it with the gauze lightly and not put it, come over here. Yep, perfect. Not to the point where you're putting any pressure on the implant itself, obviously, but just to pick up any sort of heme that might be getting in the way. Now, I've gotten a decent amount in there, so what I'm going to do now is I'm going to use my pocket pecker. So I'm going to go on the facial, so notice the direction here. I'm going to go on the facial, and I'm just going to tap lightly on the bone on the facial. And that is, what we're doing here is, if you've ever done any work with gravel and use a tamper before you actually pour your concrete, that's what we're doing. So we're just tapping lightly. There's very little force here. We're just using a little bit of vibration to help set the bone particles, because they're odd shaped and we want them to kind of sit into each other a little bit better than they do naturally. Okay, one more. All right, so I'm going to come right off the front. I'm working just on the facial right now. We'll check the lingual here in just a second. Now you don't want to pack this like you're packing, black powder in a rifle or something. You just want to really lightly tap this in here. You want to make sure you have blood flowing in between your allograft, because you want that blood to bring all the mediators there for growth. Okay, so that's looking pretty good. Now, I like that pretty good. I don't want to go much higher than that. If I was to go higher than that, what will happen is the bone graft will slough off, and then the patient will be worried. Okay, so we have a hole in the lingual, and then when the patient's worried, what do? They call you, and then you say, well, I don't know, you've got to come in, and now you have a follow-up visit, and then when they come in, everything looks great, except they lost those couple of particles that you tried to overbuild on the facial or on top of your graft. So the rule that we have is that we don't want to take the graft any higher than the surrounding blood supply. So the tissues that surround the graft, that's as high as we want to go, because we're not going to grow any bone above that. There's no blood supply. It won't grow. All right, so we've gotten a little bit of bone down on the lingual. That's feeling pretty good. And this might be the last one here, Sarah. Mm-hmm. All right, so we're just tapping. Now this is where my perfectionism comes in. So I like to tap probably a little longer than I need to, but I really like this thing to be really pretty before we go for the final stage here. So
Negative.
we're almost done there, and I'm going to check that lingual one more time. No, I think we're good. Yeah, that's good there. No, I'm good. I'm going to go here. Okay, and then on the distal. Okay, so, all right, so let me stop for a second here and show you what we've got, and then we'll tell you how we're going to proceed. Okay, so the extraction's done, the implant's placed, and if I can give this a really good view here, let me bring this one up a little bit. There we go. So you can see we're centered between the two teeth, between the canine and the premolar. We've got a good amount of bone on the buccal. This healing abutment is smaller than the implant. Remember, the implant is a 3.8, but the healing abutment is only a 3 millimeter in diameter because we used platform switched. So don't think that the smallness of this is indicative of the implant that's underneath it. The implant's actually properly sized for the premolar location. The other thing about using a little bit smaller platform switched abutment like this is it allows more soft tissue to grow, because what you're going to see here is that we don't have tissue over the extraction site because it hasn't grown yet. But over the next couple weeks, what's going to happen is that's going to form keratinized attached gingiva over the extraction. So if I was to put a bigger healing abutment on there, what would happen would be is I'd grow less tissue. So by starting with a smaller one, when we get to our prosthetic workup later, I actually have more tissue to work with, and I'm pretty sure everyone here can appreciate having more. So what we've got here now is cyanoacrylate. This is made by Glue Stitch, and it comes in it's a medical grade super glue. So do not buy this from Home Depot to try to save a buck, because that's not the same chemicals, okay? And what we've done is we've drawn a little bit up and into a pipette, and we're going to do is we're going to spot weld this. Note that here on the buckle, I haven't done a full thickness flap. All I did was really elevate the papilla. So I just want to kind of help to encourage them to stay into place. So I'm just going to touch right at the distal of the canine here, and that's it. And I'm going to go to the mesial of the premolar, and I'm going to touch right there, and that's it. Okay, now I'm going to go to the lingual. Pull that out there. Okay, I'm going to go to the lingual, and I'm just going to touch a little bit right there. And I'm going to go to the mesial lingual and get my angulation here. And I'm going to touch just like that. Okay, and that's all I'm going to do. Now, we just use super glue, and normally we don't have the distinct advantage of having the patient under general anesthesia. So normally we would have a patient that would be moving around. So what we do is we follow it up with Vaseline. And what we're going to do is we're going to lube the cheek, the buccal vestibule, the palate, anywhere where we think they might get stuck. Before we do that, let me show you on the mirror what the glue looks like before we close up. Now, there you go. Okay, so notice I only tacked around the edges, and I did not float it over the entire graft. That graft will form a clot in the next, from 10 minutes from the placement to the end, the initial blood clot will form. And after that, the fibrin will kick in and really secure that graft. That graft will not fall out. I do not need to put a collagen membrane over it, and I do not need to put a suture over it. I haven't elevated any tissue. That tissue is not going to go anywhere as long as the patient doesn't chew on that site. So now the Vaseline comes in, and we start by just kind of rubbing it in with the cotton swab that helps us get into locations that we need to get into. And then what I like to do is use the finger. So we come in on the buccal and just make sure that we don't have any issues with this tongue getting stuck or the lip getting stuck to the extraction site. Can I get that?
What
Yeah.
is the dry time for the
What is the dry time? The question is, what is the dry? Can I get the gauze back, the cotton swab, and just wipe off the excess? Yeah. So the question is, what's the dry time of the periaqueal? The periaqueal is water cured. It dries almost instantly. In fact, this little tag right here, do you see that? That's a piece of the glue that's already dried right there. So that just fell off, so I'm going to move that out of the way. So it dries really, really quickly. Now, if you pull it, which I don't encourage you to do, but if you were, the pool will take a little longer to cure until it touches some water. Now, what's neat about this is look at the hemorrhaging that we have here. It's almost next to none. And I like the analogy of the fighter in the ring when they get cut and they use the Vaseline to help reduce the bleeding. So we have very little bleeding. When we do a case like this and the patient leaves, even on an extraction site, they're leaving and they're not hemorrhaging. And this is a really good practice builder. The whole reason why we're doing an immediate implant placement in an extraction site is based on Dr. Tarnow's work out of New York. He did a really lovely paper a number of years ago that I highly recommend everyone obtain. And it talks about how well a site will heal if you can get an implant in and a graft and a provisionalized custom abutment. You'll get the best results. So in the posterior, we're not too terribly worried about losing papilla interproximally. So in this case, we don't have a custom abutment. If we were in the aesthetic zone up in the anterior, we would have put a custom abutment on here or done a non-functional provisionalization in the anterior. But in this particular location, I'm pleased with that. It's going to heal just fine. So let's come back now that we've got the glue in and we've got it all sealed up. And that's what we're talking about right there. So let me get my thumb out of the way. Okay. And that's how we do an immediate extraction, immediate placement of an implant. and grafting all in one appointment. We don't, if I wasn't narrating this whole case probably would have taken about 10 minutes for this location. With the narration, obviously, we went a little slower, but we can go to cam 2, I think, right now.
Yes, sir.
So if we don't have any other questions, that's pretty much it for today's video, and look forward to seeing you guys again. In the future, we're going to be doing some more of this stuff, because this is really your entry level for most folks. If you're getting started with implants, starting with single units is obviously where you want to start. You don't want to start with full mouth. But we want to show you how to do this in a healed site as well. And in a healed site, we typically show placements without narration. We could probably place an implant in about 4 minutes. And that's another really big practice booster, because when you place an implant in 4 minutes and the patient's not bleeding when they leave, they really like that. And that's a good thing for your practice, and it's a good thing for the patient as well. So we look forward to seeing you guys in the future with some other single units, and then we'll bringing some more complex cases that will include more use of the new Action piezo and some other instruments that we haven't had a chance to show you yet. Thank you for your